This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, let's look at a routine case of phacoemulsification in a young patient. He is a 35-year-old gentleman who has had a renal transplant about 18 months back, for which he was put on systemic steroids as part of the immunosuppression regime, and because of the steroids, he has developed this post-subcapsular cataract, and for that he has come for surgery. In all my videos, I make it a point to always tell the age of the patient because it has got certain clinical implications, and at different age groups, the ocular tissues behave in a different way. The scleral rigidity is different, the intercapsular tone is different, the elasticity of the capsule is different. The way the eye behaves at different age groups is going to be significantly different. So he is a young patient, and let's try to discuss how typically these cataracts would be and what are the challenging steps. To begin with, the pupil is extremely well dilated. When we have such an extremely well dilated pupil, it makes sense for us to use some corneal marker which acts as a guide to ensure that we have an appropriately sized and well-centered rhexis. Of course, I'm not using any of these devices in this eye, but always makes sense to use one such device just to mark it on the cornea so that we have a rough guide so that the rhexis is appropriate. There are many markers like this which I'm using in some other case just to show you that this gives a marking on the cornea which corresponds to about 5 mm of Capsulorhexis opening. And it would be a wise decision to use such devices in such eyes where the pupils are extremely well dilated. The glow is excellent. I don't need to use a dye, but because as an young patient, I use dye not for staining, just to make the capsule less elastic. I believe the trypan blue has some role in that, so I'm using trypan blue for that. The antechamber is pressurized with dispersive OVD. Initial puncture the capsule is done with a 26 number needle. I'm stabilizing the globe with an Sinscue through the side port incision. I'm going to switch to forceps to perform the rhexis. Now, as I told, I'm not using any corneal marker, which I should have, but I'm just relying on my mental marker to do the job here, and hopefully it turns out well. I'm trying to be as slow and as meticulous as possible. My goal is to aim for a 4.5 mm rhexis, and these younger elastic capsules, it eventually becomes 5 mm, although I aim at 4. The rhexis is complete. It looks a little bit small, underwhelming compared to the extremely large, well-dilated pupil. But let's see, once I put in the lens, we'll come to the exact size of the opening. In young patients, I think the most challenging step is always to get the rhexis right, because nucleus management is going to be extremely easy. These are soft lenses and they can be aspirated out in a jiffy. So just sizing and centering your rhexis appropriately is probably the most key step in these young patients. We need to remember that these patients have low scleral rigidity. So when we're operating in topical anesthesia, it makes sense for us to go in with a slightly low bottle height and then gradually increase the bottle height to ensure that the patient is comfortable enough. The OVD is burped out, and then I'm going to perform hydrodissection. Posterior fluid wave is seen, and I'm trying to decompress the lens, and at the same time trying to do some hydrodelineation as well. I thought the lens is soft enough, and maybe I can consider using the irrigation aspiration system to just aspirate out the soft lens. I'm going in with my bimanual irrigation aspiration and trying to aspirate the lens out. I could get hold of the cortex and the cortex could be stripped, but quickly I realized that it's not possible for me to aspirate the nucleus through this small aspiration port. Quickly I switch over to my Phaco probe and go in with a Sinscue hook just to mobilize the nucleus around. The nucleus is mobilized around so that I just get a cleavage plane. The settings which I'm going to use is just the epinucleus settings. The Phaco power is going to be ultra low, just using the flow rate and the vacuum to nudge the nucleus around and get hold of it and then aspirate out the nucleus and the epinucleus. These patients have this gummy cortex, and it's usually comes along with the epinucleus itself. So the bag looks to be very clean except for few fibers sticking around in these regions, and it's time to remove them using the bimanual irrigation aspiration. Just want to bring this thing to your notice. The moment the irrigation handpiece goes in, suddenly you can see the deepening of the antechamber. This is seen in younger patients because of the lower scleral rigidity. And that's the reason why I keep on telling always that watch out for the bottle height in such young patients. This is okay in a healthy eye, but in case of postipolar cataract, this sudden deepening of the chamber itself will cause rupture of the posterior capsule. So be mindful of this aspect of scleral rigidity in these young patients. So the cortex is aspirated out and time to implant the lens. The bag is filled with OVD. A single piece hydrophobic lens is being implanted into the eye. The pupil is extremely well dilated and I can see up to the equator of the capsular bag. This gives me a nice opportunity to go ahead and clean the anticapsule up to the equator. So I'm going to use Dr. Singer's sweep to just polish the anticapsule. It's just a flat spatula-like instrument and which is just swept under the anticapsule. We can reach up to the equator and this helps us to clean the anticapsule of all the epithelial cells. It's a rare thing for us to have access to this equatorial view of the capsular bag. Very rarely in such young patients we have this opportunity. I'm just using it to clean the capsular bag. Of course, we can always use the bimanual irrigation aspiration handpiece itself to do the job, or your coaxial IA cannula itself. And again, it's debatable whether the anticapsular polishing and the equatorial cell polishing, how much impact does it have on the PCO formation. But nevertheless, it is quite pleasing to have a bag which is very clean, at least on the table. Time to remove the OVD both in front and behind the lens. The side ports are hydrated, that's it, the case is done. To summarize, in young patients, managing the nucleus is going to be extremely quick and easy. The nucleus is going to be very soft, and usually with just the epinucleus settings, we can manage the nucleus after doing a gentle hydrodissection. In the young, we need to remember that we'll be dealing with low scleral rigidity. The patient might complain of pain during surgery because of the ciliary body stretch, which happens because of the sudden deepening of the chamber. Number 2, we need to be mindful of the elastic capsule. We need to have a capsule which is appropriately sized. So using a corneal marker, especially in eyes with such very well dilated pupils, does make the job easier. So trying to aim for a rhexis which is slightly smaller will eventually lead to an appropriately sized rhexis. So these were the few points from this surgery in an young patient. Thank you for watching and hope you found this helpful.